Hello everyone, it's Dr. Mohib, and in this lecture we will be going through Wiggers diagram. Now the topics covered in this lecture are Wiggers diagram, cardiac cycle, electrical activity of the heart, pressure changes, volume changes, heart sounds, and at last some memory drills. Now this is a Wiggers diagram. In Wiggers diagram, we combine different parameters of cardiac physiology. On x-axis we have time, while on y-axis we have different parameters of cardiac physiology. We have electrical activity, right atrial pressure changes, volume changes, heart sounds, and left ventricle pressure changes. In other words, Wigger diagram shows a one-stop or one diagram changes occurring within the cardiac cycle or the heart. Now let's go toward cardiac cycle. So first of all, what is cardiac cycle? The series of events or changes that occur within each heartbeat is known as cardiac cycle. It is divided into two phases: a systole, where heart contracts and pumps blood, and a diastole, where heart relaxes and stores or accumulates blood. The normal duration of normal heart is, or the duration of normal cardiac cycle is up to 8 seconds, out of which 0.3 second is a systole while 0.5 second is a diastole. The systole is further divided into atrial systole and a ventricular systole. Same goes to diastole. We have an atrial diastole as well as a ventricular diastole. Now let's come toward the Wiggers diagram. If we look at the Wiggers diagram, at the bottom we have electrical activity or the ECG changes. The ECG changes are somewhat like this, or at first we have a P wave followed by QRS complex, then we have a T wave, and again we have a P wave. So if we extrapolate it, it will come somewhat so, and it will repeat. Now, what is electrical activity? Unlike other organs of our body, heart is a special muscular organ which generates or possesses an intrinsic electrical activity generation capability. So it can generate its own electrical activity or it can generate the stimulus for contractility by its own, unlike other organs or muscles. For instance, bicep. Now for a bicep to contract, it needs a stimulus from a CNS to contract, while on other hand, the heart doesn't need a stimulus from CNS. It has its own electrical activity generation capability, which gives it a stimulus to contract. So let's review the electrical activity. First of all, we have a P wave. P wave shows atrial depolarization. If you look at the cardiac cycle, P wave shows depolarization of atria. The QRS complex shows depolarization of ventricles, while T wave shows repolarization of ventricles. The depolarization serves as a stimulus for contraction, or in other words, systole, while the repolarization serves as a stimulus for relaxation or diastole. This was all about the electrical activity. If we look at the cardiac cycle or the Wiggers diagram, we have an atrial systole, then we have ventricular systole as well as ventricular diastole. The ventricular systole and diastole are further divided into different phases in terms of volume and pressure changes. It is divided into isovolumetric contraction, rapid ejection, and reduced ejection phases. Same goes to diastole. We have isovolumetric relaxation phase followed by rapid filling and reduced filling. If we look at the electrical activity as well as the different phases, we don't see the phase of ventricular, sorry, we don't see the phase of atrial diastole. Actually, the phase of atrial diastole is masked by QRX complex. When the ventricle is contracting at that particular instant, we have the relaxation of atria. So the relaxation of atria is masked by the ventricular systole phase. So actually, atrial diastole is occurring at this moment. This is the phase of atrial diastole. This was all about electrical activity of our heart. Now, to understand the pressure changes, we have to appreciate the different pressures within the different chambers of our heart. Now, this is the schematic diagram of this circulatory system of our body. We have right atrium, right ventricle, left atrium, and left ventricle. The, the pressure within right atrium is 5 mm of Hg, while the pressure within right ventricle is 25 over less than 5, where 25 reflects the systolic blood pressure, while less than 5 is diastolic blood pressure. And the pulmonary artery has the pressure of 25 over 8. Same goes to left atrium. We have a pressure of 12 mm of Hg. Left ventricle has a pressure of 120 over less than 12, and the pressure within the aorta is 120 over 80. What happens is that each of these chambers are separated by different valves. The right atrium is separated from right ventricle by a tricuspid valve. The left atrium is separated from left ventricle by mitral valve. The right ventricle is separated from pulmonary artery by pulmonic valve, and left ventricle is separated from aorta by aortic valve. When the pressure, when the valves are closed, the chambers serve as an isolated chamber, and when the valves are open, both the chambers work as a combined or a single unit. For instance, if the aortic valve is open, the pressure within left ventricle as well as aorta will be same. So what happens in normal condition? When blood reaches the left ventricle, it is accumulated within the left ventricle, and this blood is known as end diastolic volume, which is about 120 ml. Now what happens? Initially we have, this is the volume changes. Now we will start from ventricle systole. At this particular instant we have a volume over here. We will start from this phase of the Wiggers diagram, or from the 0.1 second. So first of all, what happens? We have an electrical activity or a QRS complex. This QRS complex serves as a stimulus for the depolarization of ventricles, and this depolarization serves as a stimulus for ventricular systole, or it gives the command to the ventricle to contract. So what will happen? The ventricle will start contracting. It will start contracting. At this particular instant, before contraction, the pressure within the left ventricle was less than 12. Suppose we have a pressure at this particular instant of 10 mm of Hg. This is the pressure over here. We have a pressure of 10 mm of Hg. Now the pressure within the left atrium is 12. So when the pressure of left ventricle goes above 12, at this particular instant, the connection or the mitral valve will close. So when left ventricle starts to contract, the pressure within the left ventricle starts to rise, and when it reaches above 12 mm of Hg, at that particular instant we have the closure of mitral valve, which produces S1 sound. So if you look at over here, when the pressure goes above 10 mm of Hg, suppose we have a pressure of 15 mm of Hg. At that particular instant, we have closure of mitral valve, and this produces S1 sound. I hope we are clear up to this. Now we have a phase of isovolumetric contraction. Now after this we have this phase, the phase of isovolumetric contraction. So what happens at this phase? Now we have closure of mitral valve. Now at this particular instant, the left ventricle is an isolated chamber because mitral valve is closed, which means that it has lost its connection with left atrium, as well as the aortic valve is still closed, so it is not connected to aorta as well as left atrium, and it is working as an isolated chamber. The blood is still the end diastolic volume, or the blood hasn't left the left ventricle, and left ventricle is contracting and the pressure is increasing within the left ventricle. So this contraction phase, or this phase, is known as isovolumetric contraction. This phase is known as isovolumetric contraction because the blood or the volume within the left ventricle is same while the pressure is increasing. This is the phase of isovolumetric contraction. The pressure is increasing. It has reached 20 mm of Hg, then 40 mm of Hg, 60 mm of Hg, until we have a pressure of 80 mm of Hg. While the volume changes are constant, the blood isn't leaking the left ventricle. After that, we have a phase of rapid ejection. Once the pressure has reached 80 mm of Hg, we have some changes. The pressure within the aorta is 120/80, which means that the lowest pressure within the aorta is 80 mm of Hg. So when the pressure within the left ventricle reaches above 80, then we have the opening of aortic valve. Suppose we have the pressure within the left ventricle is 85, which is higher than 80. At this particular instant, we have an opening of aortic valve, and the blood starts leaking out of left ventricle into aorta, and we have the drop within the volume of left ventricle. So what happens? We have opening of aortic valve during the rapid ejection when the pressure reaches above 80 mm of Hg. We have increase in pressure. The red line shows, sorry, I will mark it blue. The blue line shows the pressure changes within the aorta. So after the opening of aortic valve, the pressure changes within the aorta as well as left ventricle follow the same path or the same line. During rapid ejection, the pressure reaches up to 120 mm of Hg, while the blood within the left ventricle, most of the blood has left during the rapid ejection from the left ventricle. So we have a drop in left ventricular volume. After that, we have reduced ejection phase. Now, at this instant, the stimulus or the impulse for systole or ventricular contraction has faded, but still we have a forward pressure which pumps blood out of left ventricle into aorta. So we still have a volume leaving the left ventricle, but the line somewhat becomes parallel, or we have a decreased volume change. Same goes to pressure changes. The pressure reaches up to 120 mm of Hg and it starts decreasing. Same goes to aortic pressure changes. It follows the same path. Now again, when the blood or the pressure changes, so we have this blood. After contraction, the volume left within the left ventricle is known as end systolic volume. Most of the blood within the left ventricle has left, and now the new volume within the left ventricle is known as end systolic volume. So this volume that has left the left ventricle is known as stroke volume, which is equal to end diastolic volume minus end systolic volume. Usually the end diastolic volume is up to 120 ml while the end systolic volume is 50 ml. So we have a stroke volume of 70 ml. So a 70 ml of blood has left ventricle and it has been pumped into different organs of our body. Now when the stimulus for left ventricle contraction has faded, now the pressure within the left ventricle starts to decrease. So when the pressure within the left ventricle again reaches, suppose we have a pressure of 75, which is again less than 80. At this particular instant, we have the closure of aortic valve, which generates S2 sound. So we have aortic valve closure, and this aortic valve closure generates S2 sound. And this volume change from here up to here, or from this to this, is stroke volume. So now we are at this instant. Then we have a notch forming in aortic pressure changes. This specific notch formation is known as dicrotic notch. This is due to the regurgitation of blood within the aorta after the closure of aortic valve, which generates this notch known as dicrotic notch. Now, after that, T wave occurs within the electrical activity and which serves as a stimulus for ventricular diastole, and ventricles start to relax. Now the pressure starts to drop. It has peaked at 120 mm of Hg and now it again starts to drop. At less than 80, we have closure of aortic valve and we have again relaxation. This particular phase is known as isovolumetric relaxation. Again, like isovolumetric contraction, we have isovolumetric relaxation. Now we have isovolumetric relaxation. Ventricle is relaxing while mitral valve as well as aortic valve, both mitral valve and aortic valve are closed, and heart is relaxing. We have only end systolic volume. So the left ventricle is relaxing while the volume changes are constant. So this phase is known as isovolumetric relaxation phase. We have a phase of isovolumetric relaxation where pressure is dropping. From 80, it again reaches up to 12 mm of Hg, while the pressure volume changes are constant. After that, when the pressure drops below 12 mm of Hg, suppose at 10 or 8 mm of Hg, we have opening of mitral valve, which marks the phase of rapid filling. When the pressure drops below 12, because the pressure within the left atrium is 12 mm of Hg, so when the pressure within left ventricle become 10 or 8, at this moment we have opening of mitral valve. While the mitral valve was closed, we have accumulation of blood within the left atrium. So this accumulated blood after the opening of mitral valve will start pouring into left ventricle. So this phase is known as rapid filling phase. So we will have an increase within the volume of left ventricle. So the volume will start rising. So at this moment we have the heart is still relaxing, so the pressure is still dropping while the volume is increasing. After that we have reduced filling. Once all this blood has almost all this blood has been pumped into left ventricle, so we have this amount of blood. After that we have a reduced filling. At this phase the atria starts to contract, pouring the remaining blood within the left atrium into left ventricle. So this is the last phase, which is the before rapid filling, we have reduced filling during which the remaining blood is pumped. So we have increase within the volume. After that, we have atrial systole, during which atria contracts and pours the remaining blood within the left atrium into left ventricle. And again, we have this pressure changes. So this was all about the pressure and volume changes within the, or the Wiggers diagram, different pressure changes as well as volumetric changes. And the cycle goes on. Now different let's review or let's read the first aid. Sorry, one thing I have to mention is the time. The normal or the time frame of this cardiac cycle is 0.8 seconds, which can give us the clue of the heart rate. If we divide 60 by 0.8, it will give us 75. So this means that the heart rate of this particular heart is 75 beats per minute. Now let's review heart sounds. We have two heart sounds, S1 and S2. S1 is produced by the closure of mitral and tricuspid valve, while S2 is produced by aortic and pulmonic valve. S1 is produced by mitral and tricuspid valve closure. It is loudest at mitral area, while S2 is produced by aortic and pulmonic valve closure, loudest at left upper sternal border. If we look at the chest, we have sternum followed by different ribs. Now the second intercostal space, we have the right upper sternal border is known as A area or aortic area. The left upper sternal border is known as P area or pulmonic area. This is second intercostal space. At fourth intercostal space, we have tricuspid area, and at the mid clavicular line we have mitral area. So the S1 sound is heard best at the mitral area, which is located at the mid-clavicular line of fourth intercostal space, while S2 is heard best at left upper sternal border. We have this is sternum, this is left upper sternal or the pulmonic area. So S2 is heard best at the pulmonic area. Beside S1, S2, we have other heart sounds S3 and S4. These are also known as galloping heart sounds, or they are abnormal heart sounds. They are not present in normal individuals. So what is S3? S3 is caused by increased left atrial pressure. When we have increased left atrial pressure and the blood pushes from left atria with this increased pressure into left ventricle, this this generates or produces a murmur or sound known as S3. So S3 is caused by increased left atrial pressure, which in turn leads to increased left ventricular and and systolic pressure or volume. So when we have a blood pumped against increased end systolic volume, the turbulence caused by this will generate S3. So what are the conditions which leads to increased end systolic volume? So S3 occurs in early diastole during rapid ventricular filling phase. So if you look at the ventricular diastole, so S3 occurs during the rapid filling phase of the ventricular diastole, because at this particular instant we have the opening of mitral valve and blood starts leaking into left ventricle. So the S3 is best heard at apex with patient in left lateral decubitus position associated with increased filling pressures, as I have mentioned earlier. So what are the conditions which leads to increased filling pressure? In mitral regurgitation, we have increased filling pressure, same goes to aortic regurgitation, in heart failure and thyrotoxicosis. In all these conditions, we have increased filling pressure. In mitral regurgitation, the blood starts leaking. Instead of going from the normal pathway from left ventricle into aorta, some blood leaks from left ventricle into left atrium. In aortic regurgitation, the blood from aorta leaks back into left ventricle, which leads to increased filling pressure. In heart failure, the heart has lost its capability to pump blood from left ventricle, and which leads to increased filling pressure, while in thyrotoxicosis we have increased venous return. The heart still has increased its stroke volume, but the blood coming back into left ventricle has increased, which leads to increased feeling pressure, and in thyrotoxicosis, which leads to high cardiac output failure due to the increased venous return. All these conditions leads to increased feeling pressure, and these are more common in dilated ventricles. But all of this, but the S3 can be normal. So what are the conditions in which we have this S3 finding as a normal finding? In children, in young adults, athletes, and pregnancy. In all these conditions, when we have a finding of S3, it is considered as a normal finding. In all of these conditions, we have increased end systolic volume, but this time the end systolic volume is not caused by increase. Sorry, the increased end systolic volume is caused due to vigorous relaxation of left ventricles. We have vigorous relaxation of left ventricles, which causes the gradient or the pressure gradient for left atrium to pump blood more vigorously into left ventricle, causing the turbulence or generation of S3. The turbulence caused by blood from left atrium mixing with increased and systolic volume. This leads to generation of S3. Then we have another heart sound known as S4, which occurs in late diastole or during the atrial systole phase, also known as atrial kick. If we look at the Wiggers diagram, S4 occurs during the phase of atrial diastole. So what happens during S4 or late diastole? The S4 is caused by the when the blood from atria is pumped against stiff ventricles. This generates heart sound and S4. So turbulence caused by blood entering stiffened left ventricle. It is also best heard at apex with patient in left lateral decubitus position. The mitral area is also known as apex. So if we turn the patient into left lateral position, decubitus position, the S3 and S4 can be heard at this area. In this condition, again, we have high atrial pressure. This is associated with ventricular non-compliance. In other words, the conditions in which we have stiffened left ventricles. For instance, in hypertrophy, it is considered abnormal if palpable. In older patient, it is considered normal because we have somewhat hypertrophy of left ventricle. It won't be present in conditions in which we don't have atrial kick. So what are the conditions? In atrial fibrillation, we don't have an atrial kick or the proper atrial systole. So in atrial fibrillation, we won't have an S4 even if we have a ventricular non-compliance or stiffened ventricles. So this was all about heart sounds. Now let's review jugular venous pressure. We, if you look at the chart, I will clear. We have two type of pressure tracings on this chart. We have right atrial pressure changes. We look over here. These are atrial pressure changes as well as ventricular pressure changes. These are ventricular pressure changes. So what happens in atrial pressure? If you look at this, the right atrial pressure gives us a clue about, or it is continuous with, since atria are directly connected to vena cavas, so it gives us clue about the pressure within the jugular veins. So the right atrial pressure is an equivalent of jugular venous pressure. What are the components of atrial pressure? We have an A wave, then we have C wave, followed by X descent, then we have V wave, followed by Y descent, again we have A, followed by C, and again. So this is all about atrial pressure. Now let's review. First of all, jugular venous pressure. First of all, we have A wave. When does A wave occur? A wave occur during atrial contraction. If we look at this phase, when atria contracts, it generates A wave. If we look at over here, now if we have pressure changes over here, so when atria contracts, and we look at the pressure tracings of the atria, then we will have, first of all, we will have an A wave. Then after that, when the atrial systole has vanished and ventricle starts to contract, initially atria contracts, we have A wave. After atrial contraction, we have ventricular contraction. Ventricle starts to contract and mitral valve closes. So during this contraction, the mitral valve indents or it moves into left atrium, which generates a C wave. So C wave is caused by the closed mitral valve, or if in terms of right atrium, we have tricuspid valve. So in terms of right atrium, the closed tricuspid valve, when it is pushed into right atrium while the right ventricle is contracting, this generates C wave. So we have A wave, C wave, then X descent. X descent means the relaxation of atria. Then we have V wave. V wave is caused by the accumulation of blood, the blood reaching the atrium. For left atrium, the blood reaching or coming from the pulmonary veins, while for right atrium, the blood coming from inferior as well as superior vena cava. So the accumulation of blood within the right atrium generates V wave, and after we have Y wave, which is the emptying of blood from the atrium into ventricle. For right atrium, the blood coming from right atrium into right ventricle after the opening of tricuspid valve. So this was all about the pressure tracings. This was all about now. A wave occurs during atrial contraction. It is prominent in AV dissociation, also known as Cannon A wave, and increase in right ventricular and diastolic pressure from any cause, and it is absent in atrial fibrillation. So this is normal jugular venous tracings. We have A wave followed by C, X descent, V wave, and Y wave. Now what happens in atrial fibrillation? We have absent A waves. We have C wave followed by X, then V, Y, again we have C wave, X. We don't have the, in normal tracing we have three contractions or three peaks, A, C, and V, while in AFib we have C peak and V peak. This is due to the absence of A waves. Why? Because in atrial fibrillation we have consistent stimulus or fast stimuli reaching the left atrium instead of a proper stimulus for atrial contraction. So in atrial fibrillation, we have rapid stimuli coming towards the atria, while atria doesn't have an ample time to contract. So instead of a normal contraction of an atria, we don't have a normal or sustained contraction. So we have an absence of atrial systole, which usually generates A wave. And the A wave is prominent in a condition known as AV dissociation, which generates a Cannon A wave. So what happens in that phase? In AV dissociation, we have a peak A wave followed by a CX, VY, then again we have a peak. So this peaked A wave is known as Cannon A wave, which is a hallmark feature of AV dissociation. Usually we have atria, then we have ventricles. Suppose if we consider it for right sided heart, this is right atrium, right ventricle, and pulmonary artery. We have pulmonic wall over here and tricuspid wall over here. So what happens is that right atria contracts, it generates A wave. We have right atria contracts, it pumps blood into right ventricle, and we have, as a result, we have A wave. This is a normal condition. So what happens in AV dissociation? In AV dissociation, atria contracts on its own, independent of ventricle, while ventricle is contracting on its own. So if atria is contracting, while there is a chance that ventricle is also contracting at that moment. So what happens at that moment? As a result, we will have a closure of tricuspid valve due to the contraction of right ventricle. So when the tricuspid valve is closed and right atria starts to contract against closed tricuspid valve, we will have a massive A wave. So the massive A wave generation is due to the contraction of right atrium against closed tricuspid valve. In other words, we can diagnose AV dissociation if we have a jugular venous pressure tracings of a patient, and we a don't have an electrical activity of this of that particular patient. So this was all about A wave. Then we have C wave. C wave is caused by right ventricular contraction, the closed tricuspid valve bulging into atrium. Then we have X descent. The atria starts to relax and downward displacement of closed tricuspid valve during rapid ventricular ejection phase. It is reduced or absent in tricuspid regurgitation and right heart failure because pressure gradients are reduced. So if you look at this, so this decrease or this downward slope, also known as X descent, is due to the decrease in pressure. So why does this decrease occurs? Because the blood moves from from right atrium into right ventricle, which leads to a decrease within the pressure. So any condition which leads to increased pressure within right atrium will minimizes or decreases this X descent. So we won't have X descent. So what are the conditions? In tricuspid regurgitation, in tricuspid regurgitation, when right ventricle contracts, the blood moves from right ventricle into pulmonary artery, but some blood leak back into right atrium. So instead of normal X descent, we have absent or decreased descent. Same goes to right heart failure. In right heart failure, the blood is accumulated within the right ventricle, so some blood again leaks back into right atrium, which decreases the descent. So we have pressure tracing somewhat like this. We have A wave, then we have CV wave, then we have Y descent. So in A wave followed by C wave, we don't have an X descent again direct, we have V wave. This was about X descent. Then we have V wave. V wave is caused by increased right atrial pressure due to volume against closed tricuspid valve. The V wave, this is V wave, is all the changes are occurring within the ventricle. The blood is coming into atrium, which leads to accumulation of blood, and this accumulation of blood leads to increased pressure, or the we have a generation of V wave. So V wave is due to increased right atrial pressure due to accumulation of blood within the atrium. Then we have Y descent. Y descent is due to right atria emptying into right ventricle. It is prominent in constrictive pericarditis and absent in cardiac tamponade. We have two conditions, constrictive pericarditis and cardiac tamponade. Now to understand this, if you look at heart, this is heart. Heart is a double layered organ. We have outer layer and we have inner layer. Between these two layers we have a pericardial space. So what happens in cardiac tamponade? We have excessive accumulation of blood within the pericardial space, which leads to compression of different chambers, while in constrictive pericarditis we have fibrosis, or we have attachment of outer and inner layers. So both of these conditions leads to increased pressure or increased compressive pressure on the different chambers. So what is the result of these different changes? It leads to prominent Y wave. Now what happens in constrictive pericarditis? In constrictive pericarditis we have prominent Y wave. Both of these changes affect ventricular diastole. Both constrictive pericarditis as well as cardiac tamponade, we have compressive forces on ventricle which affects its relaxation. So we don't have, sorry, we have compression or compressive forces both on ventricle as well as atria. So it doesn't let the ventricles as well as atria relax properly. So what we will have as a result, we will have compromised Y wave. So what happens in constrictive pericarditis? In constrictive pericarditis we have affected rapid filling phase. So what we will have, sorry, in constrictive pericarditis we have affected reduced filling phase, while rapid filling phase is occurring normally. So the wave has to do the job of both the reduced filling phase too. So we have a sharp Y wave. The rapid filling phase has to do the job of reduced filling phase too. So we will have increased rapid filling, and this increased rapid filling generates Y wave. So we will have a prominent Y wave. This specific pressure tracings is known as dip and plateau phase. We have A wave followed by X, then we have V wave, then we have sharp Y wave followed by plateau. So this is known as dip and plateau. And on other hand, in cardiac tamponade, we have both compromised rapid filling as well as reduced filling. So we don't have a typical Y wave. This is A wave, C wave, X wave, then we have V wave. We don't have the usual Y wave. This was all about the Wiggers diagram. Now let's review some memory drills. Now S1 corresponds to closure of which valve? Is it aortic and pulmonic, mitral and tricuspid, mitral and aortic, and tricuspid and pulmonic? Pause the video and think about it. And the correct option is mitral and tricuspid valve. Then we have a giant cannon wave, A wave appears in which phase? Is it atrial fibrillation, AV dissociation, right heart failure, or cardiac tamponade? Pause the video, and the correct option is AV dissociation. And at last, the dichrotic notch on the aortic pressure curve represents what? Is it aortic valve opening, aortic valve closing, mitral valve opening, or ventricular systole? And the correct option is aortic valve closing. Thank you.